Good morning, everyone. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Trauma-Informed Care for Adolescents. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Before we get started, let's go over a couple of technical details. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. Please use the Q&A panel to send questions you may have as you think of them. The presenter will answer questions at our break today and again at the end of the presentation. Our audio is being broadcast through the internet to your computer. You must have speakers attached to your computer and have the correct software and the volume on. If you do experience poor computer audio, there are a few options to try on screen right now, and I've also put these options in the chat panel too, so you can open that and look at those options there as well. You must be connected to the audio portion of the presentation and view it on screen to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 5 business days. Also, a PDF version of the PowerPoint presentation will be emailed to participants within 5 days. Approximately 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and also for persons credentialed through the Florida Certification Board. At the event's conclusion, the web browser will direct participants to an evaluation form on the FADA website. We value your input, of course, on all of our educational offerings, and we use your feedback to improve our online events. If you would like to receive CE credits or a certificate of attendance for this event, you must complete the evaluation. Be sure to include any Florida license number, if applicable, for reporting to CE Broker, along with the prefix for your license number. Your certificate of attendance will be delivered to your email address within 5 business days. Do note, please, that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. This attendance log and the evaluation forms are used to validate the provision of contact hours or the certificates of attendance. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial credit. I'd like to introduce our presenter for today's webinar. Susie Kowalsky, MA, LCPC, is the co-owner, founder of Roots Counseling and Training Solutions. Susie has conducted regional and national trainings for the National Healthcare for the Homeless Council on trauma-informed care, trauma therapy, harm reduction, integrated co-occurring treatment, motivational interviewing, and evidence-based clinical interventions. She also provides case consultation and supervision toward licensure. Susie has over a decade of direct clinical experience working to address issues related to complex trauma, dissociative disorders, substance use, serious and persistent mental illness, gender identity and expression, sexual orientation and sexual health, chronic health conditions, multiple comorbidities, and systemic oppression. Susie received an MA in counseling psychology from the University of Colorado and is a licensed clinical professional counselor. She has previously worked for Heartland Alliance and Chicago House and is currently the team leader for Threshold's Substance Use Treatment Program in Chicago, Illinois. And we're very pleased to have Susie Kowalsky join us today. And Susie, if you're ready, I'm going to switch over to your presentation and give you control.
Great. Thank you, Leanne. So good morning, everyone. I'm thrilled to be spending the morning with all of you. So thank you for setting some time aside this morning to learn about what it means to be trauma-informed when working with adolescents. Sorry.
And Susie, yeah, there you go.
Okay. Thank you, Leanne. So here's my information. This is how you can get in touch with me. As Leanne mentioned, I right now work in an outpatient substance use treatment program in Chicago. So you all can see that we're wearing coats here. It is very cold. I'm very envious of all of you in the warm weather. But in my current role, I get to work directly with the individuals that we serve by providing group and individual therapy. But I also get to supervise the other counselors in our program. So I definitely know how challenging and rewarding this work can be. I'd just like to start off this morning by thanking all of you for your service. I have such a deep respect for the people we serve and for the people who choose to do this work. And I know that oftentimes a lot of the staff don't feel well enough supported in their jobs. So that's really what spurred me to begin providing more training through Root Counseling and Training Solutions. So here are some ways to get in touch with me, and I'm thrilled that you're all taking some time this morning for yourselves to think about your practice and how we can be more trauma-informed. So here's kind of a roadmap for the day, for the morning. We're going to focus on being able to understand the connection between traumatic events and behavioral health concerns. We're going to recognize what the symptoms of traumatic experiences are, particularly through a strengths-based framework, and then identify appropriate evidence-based clinical interventions to establish and maintain safety, as well as treat this population. Before I dive into the material, anytime I do a training on trauma or trauma-informed care, I like to set some guidelines at the beginning. I think this is a good practice anytime we're working with trauma because this is really heavy material and it has the potential for a lot of impact. So it's really important to have some guidelines in place. So first and foremost, there's nothing in this training that is designed to be upsetting or shocking. So no graphic images, videos, or details of trauma stories. I am very aware that everyone on this webinar has heard things you can't ever unhear and seen things you can't ever unsee. So there's nothing in today's training that's designed to add to your collective knapsack of trauma images and knowing. So I just like people to know that at the outset, but there's nothing meant to shock you, so hopefully that helps people feel at ease. I also, over the years, have really increasingly focused on being able to talk about trauma and learn and teach about it without diving into specific details of trauma stories, which I think is an excellent practice to get into. In much the same way that we can provide trauma-informed services without knowing all of the details of people's trauma histories, we can also learn about trauma-informed care without talking too much about the actual traumas themselves. So all that being said, trauma is really personal and subjective. What's traumatic for one person isn't necessarily traumatic for another. So as we move through the material today, please pay attention to yourselves, notice what comes up for you, and really tend to yourselves. At the heart of trauma work is pacing. It's an important part of trauma work and trauma-informed care. we cannot do it all at once. We just simply can't. Trauma-informed care doesn't happen in 2 hours on a webinar. It needs to be an ongoing conversation that continues well beyond our time together today. So I like to really encourage people at the outset of the training to think about ways to bring this material back to your everyday work lives with you, and to think about how you can make your practice and your organization more trauma-informed. And there'll be some prompts for that throughout. Last but not least, I want to acknowledge that we aren't really going to talk about self-care too much today, and it always feels a little uncomfortable to me whenever I train on trauma and don't also acknowledge the necessity of self-care. Trauma and self-care go hand in hand, and not by choice, but by necessity. This is really challenging work, and the reality of vicarious trauma is a non-negotiable aspect of doing this work. It's not a matter of being a good enough clinician or worker. It's a job risk. We need to take care of ourselves in order to sustain. So I just want to point out that the lack of material specifically focused on self-care isn't at all meant to imply that it isn't important or necessary. So I'd like all of you to take out a piece of paper and draw a line down the middle and to think about 2 individuals that you currently serve, or if you're not in a direct service role, people that you've worked with in the past. And the first person, I want you to think of someone who is sort of challenging to work with, who is more difficult to serve, and who, working with that person, left you feeling a little bit drained. It was just someone that was a little more challenging. And on the other side of your paper, I'd like you to write down someone who you found very fulfilling to serve. The person that makes you feel like, yes, this is why I come up and I get up and come to work every day. Someone who maybe is a little bit easier to work with, and who you really enjoy your work with them. And there's no judgment. We all have both of these people in our work lives, and it's important for us to consider both of them. So give me a minute to write down who those people are, and we'll revisit them throughout the training. So first off, what are we talking about when we talk about trauma-informed care? In many ways, it's a good thing. It's become kind of a buzzword in the last several years. And there's a lot of different definitions out there, and people use trauma-informed care in a lot of different ways to talk about different things. So I like to just start with, what is it we're talking about? I really like SAMHSA's definition of trauma-informed care. And so they state that it is a program, an organization, or a system that, 1, realizes the widespread impact of trauma and understands potential paths for recovery. Then is able to recognize the signs and symptoms of trauma in clients, families, staff, and others involved with the system. I especially like that we talk about recognizing signs and symptoms of trauma in staff. It's something that I know most of us are pretty aware of that might be there in the people we serve, but being able to recognize that it impacts us as well is important. A trauma-informed care system is able to respond by fully integrating knowledge about trauma into policies, procedures, and practices, and then seeks to actively resist re-traumatization. So we're going to move through each of these pieces of trauma-informed care throughout the rest of the morning and kind of take them one at a time. So in order to be able to realize the widespread impact of trauma, we have to know what is it that we're talking about when we talk about trauma. Again, this has kind of become a term that people use to mean different things, and it's hard for us to have some agreement about what trauma is. So one starting place is to turn to the DSM. So the DSM really gives us a definition of trauma. We're going to return later this morning to talk about PTSD, but one of the things that they do for PTSD is identify and define what is a trauma. And, you know, different people have different feelings about the DSM. At the minimum, it gives us a really clear definition and starting point to talk about what is it that, it gives us a universal language. So they identify trauma as exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. So either directly experiencing the event or events themselves, being the person who is directly affected, witnessing this event live in person and seeing it occur to others. So this might sometimes be witnessing community violence. Learning that the traumatic event occurred to a close family member or close friend. So if one of your most near and dear loved ones experiences one of these events, that could be considered traumatic for you as well. Or experiencing repeated or extreme exposure to aversive details of the traumatic event. For this last criteria, a lot of times this can really is a pretty good description of our job and our work. On a daily basis, I am exposed to details of traumatic events. So very often this last criterion is really referring to things that happen in the course of professional duties. So not only substance use providers and social service workers, but first responders and people who work in the field where they're going to be repeatedly exposed to this. One exception to this last criteria that I think is really important is that it doesn't include indirect exposure through non-professional settings. So if it's not part of your job to be looking at images, if you're watching a lot of television shows or movies or looking at pictures that include a lot of trauma material, if it's not a part of your job, it's not included in the definition of trauma. And that's really to acknowledge the idea that there's some choice, there's a lot more choice involved when it's something that you're choosing to do outside of your work versus something that's a part of how you make your living. So this definition gives us a good starting point in thinking about what are we talking about when we talk about trauma. But a lot of people also find it to be a pretty narrow definition. It's kind of primarily focused on pretty acute incidents with specific threats of bodily harm. So looking at this definition, I know I think of things like, what about verbal and emotional abuse? Where does that fall within this definition? If someone's not, you know, verbally or emotionally threatening harm or serious injury, but is being pretty verbally and emotionally abusive, that wouldn't necessarily fall within the DSM's definition of trauma. What about neglect? Where do we see that in here? I mentioned, you know, witnessing community violence. Well, what about growing up in a neighborhood where you may not actually witness violence, but you hear ambulances and sirens day in and day out, and you know that there's violence happening, but you're not actually seeing it, and it's not necessarily happening to someone you directly know. What about homelessness? A lot of people would consider that to be pretty traumatic, but it may not fall within this definition. So I like to think about kind of broader definitions of trauma and other experiences that people can endure that might be traumatic for them. All that being said, trauma is subjective. So generally, a lot of times we agree that traumatic events are things that are sudden. They're not things we expect, and they're definitely perceived as dangerous. They involve some kind of threat to physical or mental well-being through violence or threat of violence. And trauma, by definition, is overwhelming. So it overwhelms someone's capacity to cope with an event, which is really closely related to the idea that trauma is subjective and defined by the survivor's experience of it. So for example, I work in a neighborhood that has frequent community violence. It is just an absolute reality of the area where I work. And so while community violence in general absolutely has an impact on the people I serve who live in that area, many of them grew up in that area, as a part of my work, I witnessed a specific incident of community violence while I was driving to a client's home. And it had a really significant impact on me. I felt very shaky, I felt tearful, and pretty scared during it, and for quite a few days after. It really affected me. So that's something that, for me, was quite overwhelming. And the client I was visiting actually witnessed the event as well. And while it affected him, it didn't have the same effect because this is more in keeping, unfortunately, with his baseline of what he is accustomed to experiencing throughout his neighborhood. So the same incident didn't have the same effect on the people who live in that community and witness that kind of violence on a daily basis. So here we're kind of starting to talk about the difference between acute specific trauma and ongoing complicated, complex, and chronic trauma. Sometimes it's hard to tell the difference between one or the other when people have experienced repeated acute traumas. One of the ways I like to kind of differentiate that is that if you're able to notice, well, I was in a car accident, I witnessed this event, I found out that something really terrible happened to my family member, and you can sort of distinguish the effects of one trauma from another, that we're still talking about acute traumas, but acute traumas that are repeated or that have repeated. When you can't tell anymore whether the effect I'm having, the response I'm having is because of this one trauma or this kind of lifetime of exposure, that's when we're really talking about chronic and complex trauma, which is not yet in the DSM, so something to note. So trauma is very much subjective, as I mentioned, and it's not defined so much by the event, but by what happens afterward. And we'll talk about that a little bit more. So the ACEs study talks about adverse childhood experiences. So back in the 90s, the folks at Kaiser Permanente in Southern California kind of quietly conducted one of the largest studies. They had over 17,000 adults, and there were two waves of this study. They also partnered with the CDC, and they looked at how do childhood abuse and neglect affect health outcomes and well-being later in life. So they had over 17,000 people come in, had them do surveys about these 10 different experiences that they may have encountered throughout their childhood, and then asked about their current health and behavior. And what they found was really astonishing. The ACEs study established a very clear link between adverse childhood experiences, or ACEs, and chronic health conditions, different kind of medical problems, things like depression, suicide attempts, substance use disorder, intimate partner violence, sexual violence, poor work performance, or academic performance. There was a huge, huge correlation. So the ACEs study really was a landmark study that today continues to serve as the basis for a lot of trauma studies. And Dr. Robert Block, who was previously the president of the American Academy of Pediatrics, says, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today, which is a pretty incredible thing to think about, that these things that happen in childhood could be a public health issue that amounts to a crisis that our nation is facing. So what are these ACEs anyway? There's 10 of them, and they broke them into 3 categories. So generally abuse and neglect. So under abuse, we have emotional abuse, physical abuse, and sexual abuse. And then we're looking at emotional and physical neglect. And then just different challenges from the household. So someone who grew up in a household where they witnessed their mother being treated violently. Was there someone in the home who was misusing substances and maybe had a substance use disorder? Someone in the home living with a mental illness? Did your parents separate or divorce during your childhood? Was someone in your home involved with the criminal legal system? So things that, you know, a lot of people may experience have really great impacts on people's health in the long term. So looking at this list of these 10 childhood experiences, I'd like you to think about how many of the people you serve do you think had at least one of these ACEs? My guess, and I know from my experience, is that it's about 100%. The population I'm serving probably is more like minimum 6 ACEs, but there's almost everyone we encounter has experienced at least one of these ACEs. They talk about the ACE score, which kind of gives us information about cumulative childhood stress. So we look at the ACE score as just how many of these different ACEs did you experience. And studies repeatedly find that there's what's called a graded dose response relationship between the ACEs and negative health outcomes and well-being outcomes across the course of the lifespan. So dose response just means that the change in an outcome, so for instance, maybe substance use disorder, associated with different levels of exposure or doses to the stressors, which would be the ACEs. So essentially what this is telling us is that the more someone has experienced ACEs and the more ACEs they have, the more likely they are to have these negative health outcomes. And we also see that the intensity of the outcome increases. So someone who has one ACE may be at an increased likelihood to have a substance use disorder in adulthood, but someone who has more ACEs not only is very likely to live with a substance use disorder in adulthood, but the intensity of that substance use disorder may be more severe. So returning to the people that I asked you to identify before, I'd like you to identify which of these ACEs they've experienced. So I'm going to switch the screen back to the previous list so you all have that for reference. But on your sheet of paper, if you can write down, to your knowledge, which of these 10 ACEs have each of these 2 individuals experienced? All right, so we'll come back to that. But just kind of a good metric to think about when we're working with people, what's in their past. So how common is it for people to experience the ACEs? It's shockingly common. So at least 2/3 of the people reported at least one of the ACEs. What's also important to mention is that of these 17,000 study participants, this was a pretty middle-class population that was, I think, mostly white, able-bodied people who had good health insurance because they're all part of Kaiser Permanente. So we're looking at a relatively less vulnerable population, and even among those 17,000 folks, almost 2/3 of the participants experienced at least one of the ACEs. We also learned that the ACEs usually co-occur. So almost 40% of the people had 2 or more of the ACEs, and having experienced at least one of the ACEs really greatly increased the chances of having more. So this is something where we see kind of the more of them you have, the greater the risk to have even more. So, you know, I think that the ACEs study, for me, helps, thinking back to like our trauma-informed care lens, helps us really set the foundation for assuming a universal impact of trauma. We can assume and should assume that just about everyone we encounter will have experienced some amount of trauma in their lives. So I really like this. This is called the ACE pyramid. And this kind of helps us look at, this really represents sort of the conceptual framework for the study. When they were designing the study, what is it that they were trying to figure out? They were really trying to look at some of the scientific gaps about where different risk factors come from. So if we look at the third one down on the pyramid, the adoption of health risk behaviors, what they're wanting to know is what makes it likely that people are going to adopt these risky behaviors? So the 2 gaps they were kind of looking at is at the base of the pyramid, people who've experienced some kind of adverse childhood effect, how does that lead to the next 2 levels of the pyramid? How do these childhood experiences end up disrupting neurodevelopment and impairing social, cognitive, and emotional functioning? And then how does having these disruptions, the second kind of gap was looking at how do these disruptions in functioning lead to people adopting these high-risk behaviors? And it also really looks kind of across the lifespan. So going from the bottom at from conception or early childhood all the way up to death. So kind of the question they were asking is, if these risk factors for disease and disability and early mortality aren't just random, what influences them? So what the ACEs study really uncovered was how childhood experiences are strongly related to development and the prevalence of risk factors for disease, health, and social well-being across the lifespan. So making sense to folks? Feel free to write in your questions as you have them. Moving along, though, I think the ACEs study also really identifies trauma as a public health issue. So as I mentioned, thinking about how many of the people you serve have experienced at least one of the ACEs. And I'd love if people want to type in the chat, like, you know, a ballpark estimate of how many of the people you serve have experienced at least one of the ACEs. But the ACEs study really gives us data to support the notion of trauma as a public health issue. Rather than looking at trauma as being an isolated incident that happens to a specific person at a given time, we come to really see a pattern of intergenerational trauma. If we think about the people on our caseload who maybe are currently engaged in substance use, who might be living with a mental illness, who might have a criminal background, a lot of the people I serve have children. And so their children are now experiencing at least 3 of these ACEs. But at the same time, if I think about these same folks on my caseload, they also grew up in homes with perhaps emotional neglect, physical abuse. I work with a lot of people who've experienced sexual abuse. So kind of looking through the people I serve, I can see like this pattern. It's almost eerie once you start to see it, of the ACEs being transmitted across generations and throughout communities. And I'm seeing from the comments, thank you all, that you're saying, you know, at least 90%, if not more. Some are saying nearly 100%, and that most have really high ACEs score. So I know you all are working with just as impacted of a community as I am. And I'm guessing that you can also kind of trace the pattern of trauma throughout generations, that these are not things that originate with the people who are sitting in front of us day in and day out. They didn't have these childhoods with, you know, 0 ACEs and then all of a sudden present the way that they do. So I really like the ACEs study for many reasons, but at minimum, it really demonstrates to us that this is not an individual problem. Trauma is not something that happens on an individual basis, and we need to stop treating it that way, which means we also cannot respond on just an individual level. If we focus our interventions at treating just the individuals who we identify who are affected today, we're going to miss the bigger picture, because that's not the only, those aren't the only people who are being impacted. We really need to adopt a systems level response. We can't just focus on individual work. So that's really what we're doing when we talk about a trauma-informed care system. Thinking back to that definition at the beginning, we're talking about a program, an organization, or system that is able to do these 4 R's. We're kind of now covering realize. But we need to build a system that is based on the realization that trauma and its impacts are incredibly widespread. So an organization that is trauma-informed is designed to acknowledge the prevalence of trauma and the potential pathways for recovery. So the more that we perpetuate untreated, unrecognized, and unprocessed traumas, the more likely there is to be a lot of risk for more trauma on the next generation, or even among peers and within communities. If I think of the people I serve, it's certainly not just the next generation that's impacted. It's the people who live in their building. It's their friends and family members. And also, you know, one of the things I really like about trauma-informed care is that it makes space for us as service providers, that we are at increased risk for exposure to trauma, the more that we aren't able to recognize and realize the prevalence of trauma and respond in a systems-oriented way. So if we're able to end the legacy of trauma on individual levels, we're going to see a decrease of trauma on a societal level. So I see a great question here that many of the clients over 25 years across all SES have multiple ACE items, and what do we find relative to socioeconomic demographics? That is an excellent question, and to my knowledge, there hasn't been a ton of data that kind of looks at different socioeconomic demographics. And if that's your question, Tom, I'm not sure if you're asking kind of teasing apart the ACEs and different socioeconomic demographics. What I have found in my experience of working with people, and I will say most of my experience is working with pretty vulnerable populations. I have worked with people who are of a different socioeconomic status, is that the ACEs persist. That this is, you know, I think looking at the study is looking at people of a very different demographic and socioeconomic status than the people I see on a daily basis. And the ACEs are very common, which I think is really also a great piece of trauma-informed care, and this realized aspect of it is that trauma is not isolated to people living in poverty. Trauma isn't specific to people of a particular demographic. It is a very widespread and common occurrence in our country. So to that, I hope that answered your question, Tom. I think at this point we're a couple minutes early on our break, but this is a good pause. I think Leanne mentioned at the beginning that we're going to take a break. So if folks have any questions, feel free to shoot off your questions, and then we can take a quick break. What other things are people wondering about in terms of realizing the impact of trauma and how widespread it is?
And Susie, I did have one comment from someone. It comes from someone who says that they serve the homeless population, and most of their clients have reported cases of abuse and exposure to criminal activities in the home.
Yeah. So I started my career doing outreach, street outreach with people experiencing homelessness. And I think homelessness, I absolutely think of as a traumatic event that for many people becomes a chronic form of trauma, especially when we look at chronic homelessness. But homelessness is absolutely traumatic, not knowing, you know, am I going to be safe at night? If I let myself fall into a deep enough sleep, is something bad going to happen? Am I going to be okay? And one of the things that I think, you know, your comment really highlights is that trauma comes in a lot of different forms, and sometimes it looks like homelessness, and that people who are experiencing some of these different situational experiences like homelessness, which feels, you know, it's not absolutely rooted in, it's just a piece of demographic information about someone, right? The fact that someone is without a home is all it means to be homeless. So I also like to kind of dispel the idea that there's certain people who are homeless. And my experience working with people experiencing homelessness is that it is absolutely very traumatic. Thank you for your comment.
And Susie, we had one more. I'll go ahead and ask you this before we take our break. What do you see as being the biggest difference between treating someone who has experienced one traumatic event versus long-term repeated trauma? And again, it was focused kind of on the biggest difference between.
The biggest difference between treating acute trauma and treating chronic trauma, in my experience, is a lot of the protective factors that someone's encountering. So when we're working with acute trauma, a lot of times the things that keep that acute trauma from becoming chronic are the many protective factors that someone's experiencing in their lives, that they may have a support system, they may have good health insurance that allows them to access treatment and support. They may have strong social support. So I think of kind of the protective factors that limit that acute trauma to an isolated event. And then there's also different modalities for treating trauma. So we'll talk about this a little more in the second half, but I like to really distinguish between trauma-informed care and trauma-specific treatment, that they're a little bit different. So there's different treatment modalities for trauma that are found to be effective for acute trauma. So EMDR, for example, is like the first thing that jumps to mind. It has great outcomes. It's something that is proven to be very effective in addressing trauma, but it needs to be an acute trauma. A lot of the basis of EMDR is calling up specific memories and images. And if you are someone who has lived with a lifetime of exposure to trauma, EMDR is going to be less effective because you're not going to have those specific images to work with.
Thank you, Susie. That's all the questions we have right now. It's 10:45. We're going to take our break and reconvene sharply at 10:50. Thank you.
Thank you.
Susie. Hi, it's Leanne. Are you ready to resume the presentation?
I am.
Okay. So whenever you're ready, Susie.
Okay. Welcome back, everyone. So we we spent a lot of time covering that first R, which is just realizing the widespread impact of trauma. So if we're in agreement that trauma and its effects are absolutely bound to show up in our workplaces, how do we know it when we see it? What does it look like? I like to ask the question, if trauma were somehow personified and walked through our doors, would we be able to recognize it? So returning back to the DSM, this is kind of the second half of their definition for PTSD. So the first part was the traumatic event, which we talked about how they define that. And then, as I mentioned, trauma is really defined by what happens afterward and less so by the event itself. So in the immediate time after a trauma, if any of us were to experience or witness some type of traumatic event, we could expect that we might experience symptoms along 4 clusters. The first being intrusions, that we might have kind of flashbacks or intense memories, maybe even nightmares about the event that we can't really quite push out of our minds, where it's intruding on us and we don't feel able to have some space from it. We might avoid things, like if I was in a really bad car accident, I might avoid driving for a little while if I could. I might avoid driving on the highway if that's where it occurred. I might avoid some of sort of the people, places, and things associated with the event. And kind of the extreme version of avoidance is dissociation, where the impact of it is so overwhelming that we just kind of have to like turn off. If I had this car accident, I might expect to observe some negative changes in my mood and thoughts. I might feel like the world is just not a safe place. Vehicles are these dangerous machines that we fly around in. I might feel really guilty of like I should have reacted more quickly. I might feel some shame around what happened. And I might feel sort of detached and separate from people. Like I'm living in this sort of alternate universe where I'm sort of moving in parallel to people rather than among and with them. And we would expect to see some change in arousal and reactivity, where I might be kind of jumpy and have an exaggerated startle response. I think of really these changes in arousal and reactivity. I tend to be a visual person, so I like to think of it as like almost like a guitar string that's just really, really tightly wound. And we may not know that by looking at it, but if you go and pluck it, it just snaps. So someone who is really kind of tuned that way will be a reasonable response to experiencing a traumatic event. When it becomes PTSD is when that response lasts for more than a month. So for up to a whole month, people who are experiencing all of these symptom clusters, we're considering that to be a pretty normal response to a traumatic event. These are things that have an impact on us. And it also becomes PTSD when it starts to disrupt our functioning and it's getting in the way of being able to do the things that we need to do. So I like thinking about this through these 4 symptom clusters that we'll kind of revisit. But it's helpful, I think, to be familiar with these, and there are actually specific trauma interventions that are really based on providing psychoeducation to people around this. I know my experience in working with people who've experienced trauma is that they are really confused by what's happening and don't understand why they're having the response that they do. One of the reasons for it is because of how our body and brain respond to traumatic events. So I'm not sure if folks are familiar with the idea of the triune brain, but if you hold up your left hand in front of you, it kind of looks like this red part of the image on your screen. And that is really our wrist in this case, is the red part. That's really our brain stem. So these are things that our body and brain do automatically without us putting any effort into it. So things like our blood circulation, our breathing, our heart rate, while we may have some influence, these are things that happen without us consciously having to put them into motion. These are the things that just kind of like keep us alive. If you make a fist, your fist is the blue part of this picture. So this is your limbic system, which is responsible for our survival instincts. So our fight, flight, or freeze response originates in the limbic system. And our limbic system is also a lot of the emotional mechanics of our brain. So our emotional memories, expression, and processing are really housed within the limbic system. Now, if you're still holding up your left hand in front of you, like I am, if you take your right hand and place it on top of your left hand, your right hand now represents our big cerebral cortex. And this is really what distinguishes us from other creatures, is we have this big part of our brain that is responsible for logic and higher order thinking. This is kind of how our brain is organized. What happens in a trauma is that our right hand, the cerebral cortex, goes offline. And that's mainly because the things that it's capable of doing, like a lot of logic, a lot of our language is housed here, it's not going to help us survive some sort of threat to our lives. We're unlikely to, if we encounter like an alligator in a marsh, we're really unlikely to talk our way out of that situation. And so our limbic system is what activates this alarm that puts our fight, flight, or freeze response into place and connects with our brainstem to route a lot of our blood to our limbs so that we can run really fast, gives us that rush of adrenaline, turns off things like digestion because we don't need that in that moment, and really, in a remarkable way, reorganizes our body and brain in a way that is designed to keep us alive. Where this becomes kind of problematic is once that threat has passed and we are safely, we've made it to safety, we're no longer in danger, it takes a while for that system to turn off. So that's where, thinking back to the PTSD definition, it might be several weeks of experiencing things like that, but after a while, we want to return to our baseline. So PTSD is really getting stuck in our body and brain's response to the trauma, even after it has passed. And this affects us in really remarkable ways. So the after effects of trauma, we can see originate in the body's response to the original trauma. So Rachel Yehuda has done a ton of studies that give us a ton of information about cortisol. Cortisol is what we call the stress hormone. In a fight, flight, or freeze activation, when that gets turned on, it gives us this rush of cortisol. Our cortisol level peaks, which is kind of what lets us know, hey, something's up, we gotta get ready to go here. And then once the trauma or the event has passed, it peaks and hits a cutoff switch, which then returns us back down to baseline, is what kind of helps us like calm down after the fact. For people living with PTSD and who've experienced a lot of trauma, their cortisol level is elevated because their body knows there's something going on, but it never hits that peak that signals the cutoff switch. So these are individuals living with consistently elevated levels of cortisol. So they're always amped up a little bit, but never high enough to shut it off. And this cortisol is what we're referring to when we use the phrase stress kills. Cortisol is not very good for us to have in our body all the time for long periods of time. So when we have these elevated levels of cortisol, that can lead to brain trauma, increased likelihood of chronic health conditions, and can actually decrease our life expectancy. So the fascinating thing about cortisol is that the likelihood of having these consistently elevated levels of cortisol actually transmits across generations. I'm seeing a note that folks are having some difficulty hearing, so I'm sorry about that. Let me know if it continues. Martin Teicher has done a lot of research on verbal expression and the impacts, the physical impacts of abuse. And what he has found is that verbal abuse causes cellular damage to the body, especially on the verbal parts of the brain. So there's a part of our brain called Broca's area, which is responsible for speech, which shuts off during trauma and makes us unable to speak. So when people sometimes, I've heard folks talk about feeling almost guilty that they weren't able to shout for help because the part of their brain that would allow them to do that has gone offline. So that phrase, that sticks and stones may break my bones, but words can never hurt me, is categorically false. We actually now know that verbal abuse causes physical damage on the cellular level. And it is physically more difficult for people who've experienced verbal abuse to verbally express themselves. Basil van der Kolk, who I'm a total fangirl of, has done a lot of research on the ways that our bodies and brains respond to trauma. And trauma really impacts the part of the brain that communicates a lot of the physical feelings of being alive. So this is where we can kind of imagine that someone is both simultaneously hypervigilant, where they're on guard, and numb. I think of the idea of like an alarm bell ringing. So a traumatic event is going to signal the body to, it's going to set off the alarm bells. But if you always have alarm bells ringing, you're going to learn to tune it out. And so at the same time that you're kind of on edge because there's this alarm that's constantly ringing, you're also a little bit numb to it, which is part of what makes it more likely for people who've experienced trauma to have a difficult time distinguishing between safety and danger, because this like constant alarm bell has sort of distorted their ability to hear clearly, and puts people at greater risk of re-traumatization. And then Bruce Perry kind of coined the phrase that traumatic states become biological traits. And this is what we're talking about really when we talk about the effects of complex trauma, that the states we move in and out of, that if we've experienced some trauma and then move back to baseline and experience trauma, move back to baseline, that this state of being a little bit elevated, of having this trauma response, becomes more of our biological trait. It becomes our new baseline. And the earlier in life that we experience these traumas, the more and the more severe and frequent the trauma is, the more likely it is to happen. So looking again with all that in mind back at the PTSD symptoms, kind of in context of what's happening in our body and brain can be kind of helpful. So I think of these changes in arousal and reactivity that we see, kind of our fight response, that we're getting turned up, we're getting amped up and ready to go. Where it becomes a problem in the body and brain is when we're stuck in that fight, flight, or freeze response. The avoidance can be kind of seen as the flight, or trying to get some space between you and the trauma. And then the intrusions are the freeze. We're sort of frozen in this moment, and it's just happening over and over and over again, and you're re-experiencing it. So we're kind of stuck there. One of the other things that happens in our brain during a traumatic event, as I mentioned, is that our prefrontal cortex goes offline, and the part of the brain that gives our memories a sense of beginning, middle, and end, that gives context to our memories, also turns off. So we have all these really vivid memories without context. So there's not a sense of this happened yesterday or last week or last year, not today, and my response is, you know, in keeping with the idea that this is something that happened in the past, gets disrupted. And that's where we see a lot of times that people who've experienced trauma present with a lot of disorganization in their memory, and their memories are kind of fragmented, where there's little bits that kind of get piecemealed together, and they don't have like a linear time frame to them necessarily. In terms of being unable to distinguish safety from danger, we kind of talked about, so when the alarm bell is ringing all the time, you can't know if it's real or not. So our ability to orient to both safety and danger is impaired when a lot of things, or sometimes even everything, is perceived as dangerous. And then we also see for a lot of people that their own bodily reactions don't necessarily have a context or way to be interpreted and can become a trigger. So if I start to notice that my heart is beating a little bit faster, my heart rate is elevated, that could either be because I'm really excited, it could be because I'm a little bit nervous, because I'm enthusiastic about something. It could also be because I'm really scared and I feel like I'm in danger. And so it becomes hard to know why these different things are happening in our bodies, and then people become fearful not only of the traumatic event themselves, either happening in the past or reoccurring, but they become fearful of their own body's reactions. And then information that was once providing essential information about where you're at become a threat in and of themselves. So if there's, you know, one thing that I really like to emphasize to people is that PTSD and trauma responses are really housed in the body and brain. So we're talking today, though, about trauma-informed care with adolescents. And one of the nice things about trauma-informed care, before we move on from our discussion around PTSD, is that we can use trauma-informed care for people regardless of whether they've experienced and meet full criteria for PTSD. It's helpful for us to know what PTSD is, and it's a helpful kind of benchmark to understand how trauma can impact people. But someone who has experienced a traumatic event or who's been exposed to some type of, you know, adverse childhood experience, they may or may not meet full criteria for PTSD, but trauma-informed care is absolutely going to be appropriate for them, whether they've experienced that or not. Similarly, trauma-informed care really persists across the lifespan. It's not something that, you know, we necessarily do a whole lot differently for adults. Our systems are designed very similar. Once we get into what this might look like at different ages is where we see some of the differences. So looking specifically at adolescence, adolescence is a tricky time of life. I think, you know, all of us have likely gone through and completed our adolescent phase of life. And it's not most people's favorite time of life. There's a lot of change that's happening, and it's kind of confusing. So during adolescence, we're experiencing a lot of physical changes where kind of what we know about our body and being able to read our body's signals changes because our bodies are changing in really rapid and significant ways. Can folks still hear? I'm seeing that sound just went out. Can someone let me know?
Susie, you're fine. This does happen intermittently with individual participants, but you can go right ahead.
Okay, thanks, Leanne. Sorry for the folks that are having issues with sound. I know that's frustrating. But if we think about adolescence, it's just a period of really rapid change. So not only are we experiencing changes within our body, but there's a lot of psychological and social changes that happen. So our focus goes from being very often for a lot of people, really family-oriented within kind of our family of origin, to looking much more outward and looking at our peer groups. This is also where we see a lot of transitions within families where adolescents are now wanting to spend more time with their peers and be more independent from their parents. So we also sometimes, depending on how families are able to navigate these changes, it really is a challenge to the family to be able to adopt and adapt to what it means to have a child going through adolescence. And sometimes we definitely see an increase in conflict within the family. So not only are all these changes happening, but kind of that support system that many people relied on is a little bit rocky now. We see a change in the way that people make choices about their behaviors. One of the things that I think is really fascinating is that our prefrontal cortex, that big part of our brain that allows us to kind of consider multiple outcomes, to look forward and think about the consequences of different activities, to make logical, reasonable choices, is not developed yet. It doesn't really fully develop until about our mid-20s. So teenagers are not operating with a fully developed prefrontal cortex, and we're going to see a lot of risky behaviors experimented with during this time. We also see an increase in people's reactivity in terms of their emotions, but they're a lot more sensitive to different stimuli, and things are interpreted in a different way than they often were during childhood, and that they will be during adolescence, adulthood. So adolescence is where we see the onset of a lot of really serious mental health disorders as well. So there's a lot happening during this stage of life. One of the models that I find really helpful in thinking about development, but also trauma actually, is Erik Erikson's stages of development. So he talks about different tasks that we, psychosocial tasks that we encounter at each stage of development, really from birth and throughout our life. And, you know, today we're just going to focus on the ones that pertain to adolescence, but I really encourage folks to look at his stages of development through a trauma lens. They actually really nicely line up with a lot of the pieces that are going to be most significant to doing trauma work. But one of the things that Erikson kind of recognizes is that culture and relationships and society have an influence on people and their personality and how they develop. So his model is based on this premise that the stages build upon each other. And when we talk about adolescence tasks, so he's talking there about really our teenage years, about 12 to 18 or so, that their task there is identity versus role confusion. That they're trying to figure out and really search for a sense of self and who am I. It's kind of this transition, adolescence in general is a transition between childhood and adulthood, but it's being able to figure out what do I know about who I am and who I want to be in relationship to others, in relationship to myself, and kind of in this society. I worked with a very insightful, he was about 15 at the time, a 15-year-old who told me, you know, it's hard being this age because it feels like you're just trying on different versions of yourself to see what really fits. And I was blown away at his insight, but also really his accuracy. That seems like such an apt description of what's happening during adolescence, which is where it also makes sense that we're going to see some more experimentation with substance use, with different ways of being in relationships, both to your peers and your family groups. Your sense of identity as a worker. So what kind of a student are you going to be? What kind of a career are you going to have? And what feels like it fits with you? And this is also where people develop a sense of identity as sexual beings as well. So there's a lot wrapped up in this period. And the goal is to be able to come out of adolescence with a pretty strong sense of self. And kind of, in Erickson's terms, the real virtue that comes out of having a solid identity is a sense of fidelity. So I think of that as really being able to be faithful to who you are and who you are in relationship to others. If I really know myself, I'm much more likely to be able to stick to that versus this sense of role confusion where I'm just not really sure who I am or where I fit in. And so I'll kind of occupy these different roles, and there's not a sense of fidelity of me being me, if that makes sense to folks. The next stage of development that comes directly on the heels of adolescence, and that I think very often, especially for very vulnerable folks, we see happening earlier and earlier in life, is this young adulthood, which typically might start at 18, but for a lot of people we serve, might start a little bit earlier. And going, you know, through your 30s, maybe up to 40. And the task of this stage of life is really establishing a sense of intimacy versus isolation. So again, a really relational focus. And the challenge here is, can you build and maintain healthy relationships that have a sense of commitment and safety, compassion for one another, and respect for yourself and others? If we're able to establish that sense of intimacy with other people, it also serves as a really protective factor that buffers people against some of the long-lasting negative effects of trauma. One of the things we know about trauma is that what is overwhelming and intolerable in isolation is we have more capacity for it within a sense of connection. So for people who go through young adulthood with a sense of isolation, we're much more likely to see a lot of loneliness and depression, which is so highly correlated with trauma, and just a lack of positive support. So I mentioned that next stage of development and thinking forward to what will be really important to consider for folks as they move into that next stage of development, and particularly through the lens of how will that impact the way that they respond to trauma. So one of the key tasks of being trauma-informed is really learning to recognize the signs and symptoms of trauma when you see them, which can be a lot easier said than done. right? So I don't know very many people who come into my office and say, Susie, I have experienced so much betrayal in my life that I no longer trust other people, and that's why I'm just not going to open up to you about what's really going on in my life, right? People don't tell us what their trauma symptoms are a lot of the time. They're much more likely to show us. So we need to be really practiced in being able to translate between some of these different or sometimes difficult behaviors that show up in our office, and then being able to recognize them through a trauma-informed lens. So for the person who just has like a hard time getting motivated, doesn't seem like they have any internal motivation to get job training, go to school, get a job, get housed, and some people might use the term lazy. They don't seem very motivated. They want a handout. How can we reframe that and consider that through a trauma lens? Well, that might be someone who is living with depression, and we know that depression will manifest in having a diminished interest in everyday activities. Someone who complains that the service setting is just not comfortable or safe and seems really tired and poorly rested. I've heard, you know, in residential programs, sometimes we hear complaints about people who are up roaming around at night. That might be someone who has a lot of nightmares and insomnia. So it's helpful to kind of go through these different behaviors and think about what that might be showing us through a trauma response. And I see a question here. I'm going to hold that. So, Leanne, if you can kind of tally that question, I appreciate it, but I'll return to it at the end.
Okay, thank you. Right.
One of the ones that I see a lot is someone who just doesn't trust staff, who feels really targeted by others. We had this happen last week in our program that there was quite an explosive argument between some of our members, and this person literally shouted, "I feel like I have a target on my back." This is also someone who has a long history of trauma, and if we're able to view that individual as someone who has difficulty trusting people and who often has felt betrayed in their life, our response is going to be much more in keeping with a trauma-informed approach than if we think of this as someone who, you know, thinks everything's about them and won't take personal responsibility or whatever it is that we want to refer to, how we want to refer to that. So I'm going to ask you all to kind of do a similar thing. So let's go back to the folks that we started out with. And I'd like you all to fill in what are some of the behaviors that this individual demonstrates. Do they argue a lot? Do they miss a lot of appointments? Sometimes the people who are fulfilling the serve are the people who thank us all the time. A colleague of mine says we don't get paid in thank yous. Not everyone thanks us for our work. But think about the behaviors that you see from the two different people. And then consider, what does that tell you about their trauma needs? So doing kind of a very similar thing to that last graphic, of looking at what the behaviors are that they present with and how you can reframe them through a trauma lens. And some of this can be things you know about them, like that they have nightmares that make it hard for them to sleep, which makes it hard to keep scheduled appointments. And some of them might be things that you're not certain if that's the connection, but to start kind of training yourself to think in this way. And then I also think that here it's important to spend some time to think about what strengths this person demonstrates and what resources do they bring to the table, both internal resources and external ones. So, if we know that trauma is prevalent and we keep our eyes out for it and we learn to recognize it when we see it, the next piece is how do we respond? So sometimes, like Lassie here, we can see that something is going on and we can try and help out, but our response isn't necessarily the right fit for the circumstances in front of us. So I really like this graphic, which I realize is pretty small, so hopefully y'all can at least see pieces of it if you look closely. But I really like this graphic because it helps us learn to train ourselves to look at things through a trauma-informed lens. So if we reconsider the items in orange from the perspectives offered in blue, we're much more likely to respond in a way that incorporates and applies information about trauma. So looking at some of the specific examples, if we move from saying, you're crazy, to it makes sense, we're kind of recognizing that people are having a normal reaction to an abnormal set of circumstances. Other ones I like on here are people make bad choices and looking at their behavior as a problem, versus in blue, the idea that people who feel unsafe do unsafe things, and behaviors are viewed as solutions. So these are things that are really adaptive. There's a reason that people are doing the things they're doing, and if we can learn to be curious and ask about what solution is this offering, we're going to be a lot more trauma-informed. So the R part, not they're all R's, the response part of trauma-informed care is talking about fully integrating knowledge about trauma into policies, procedures, and practices. So taking policies and procedures first, how can we respond in a way that uses all of our information about trauma? So first and foremost, I think really this speaks to the need for universal screening and assessment of trauma. We know that it's there. We absolutely know, as you all said, 90%, 99.9%, we know that the people we're serving have experienced trauma. So let's be active in asking about it and assessing about it at the outset of treatment with every single person we see. By asking about trauma with everyone, we also really normalize trauma experiences. We ask about things with everyone we see when we know that they're commonly occurring. By asking about it and talking about it, we also don't contribute to a culture of silence around trauma. We know that it's there, so we're going to talk to people about it. One of the key questions, though, is how do you go about collecting that information, which we can talk about in the practices part. As far as policies and procedures, I really think it's important to be able to review and consider and update our policies for admission, assessment, referrals, treatment planning, and discharge. So what information do we require that people provide us in order to participate in treatment? As much as we want and need to ask about trauma, we also can't require that people tell us about it in order to have, a ticket to enter. We want to provide low threshold services as much as possible, meaning that there's a low barrier, as few barriers as possible to enter services. We want to focus on safety. So an assessment process that we do at my agency is we establish safety plans at admission with people who present with some safety risks. It doesn't mean that we're going to provide barriers to service, and we're going to keep the safety of them and our other individuals served and our staff in mind and have plans in place from the outset of treatment. In thinking about referrals, who do we make referrals to? Who are our community partners, and what do we know about them, and how referrals are done? You know, I think as much as possible when thinking about working with people who've experienced trauma, we want to do a warm handoff. It's really intimidating to pick up the phone and call someone and do a cold call when you've just tried to seek treatment somewhere and been told now you have to go somewhere else. In terms of treatment planning, how do we include people being served in their own care? What options do we provide them about what their goals can be? I think particularly in thinking about like a substance use treatment program, can we work with someone who doesn't have a goal of abstinence? Can we ask people what is important to them and what they want to work with and partner with them in working toward those goals? And then last but not least, as far as those policies around how people move through our programs, I think discharge is a really important thing to consider. Under what conditions are people discharged from treatment? And that's an area where I think a lot of agencies that I encounter could really use some more support and consideration of what are the things that we're willing to, remove people from services for. So all of this review and update of policies requires that we partner with the people we're serving. We can have the best intentions of how to serve people, but without their input, we're bound to miss the mark. So we need to actively partner with the individuals in our program. Cultural humility is something that I think we need to consider at every level of our programs. Who is our program designed for, and who is not going to feel at home with the way our program operates? And how can we change that to really broaden the number of people who feel welcome in our program? I think of things like the language we use on forms that people fill out at intake. So rather than asking a young adult or an adolescent, what's your mom and dad's name? Who are your parents? We could ask things like, who are the caregivers? Who are the people living in your home? Who do you identify as your chosen family? But being able to adapt our language is kind of a simple but really concrete way to demonstrate cultural humility. And then last but not least, trauma-informed care absolutely requires a commitment and support from the top down. Ground workers cannot maintain a trauma-informed system on their own. So the people who make policies, who make the decisions about policies and procedures are often not the same people who enact them. So questions like, do we use physical restraints and isolation in this organization? Are normally not made by the people who might be following through on that decision. So we need to operate through a trauma-informed lens at every level of the organization, and this really requires leadership at the agency to invest in trauma-informed practices and be willing to make adjustments to policies and procedures and support their staff and the individuals being served. So I think like one really concrete way that agencies demonstrate commitment to trauma-informed care is something like sending their staff to a training and making sure that there's time for the people doing the work to have some space away from their everyday work to learn about this and think about this and bring it back to the organization. So that's a little bit about some of the ideas of policies and procedures. And then what does that look like in practice? So we want to consider the environment and setting that we're in. So things like, is it really noisy here? What's the temperature like? How crowded is it? Is everyone kind of cramped into a small space? And how is that going to affect people who we know are coming in with a trauma history? One of the greatest ways I think we have opportunity with everyone we serve to talk to them and demonstrate trauma-informed practices is when we talk to them about what their rights are. So I know that when we're doing intake, sometimes the paperwork feels like something we want to just sort of rush through and finish up. But I actually really like this as an opportunity to heavily emphasize the people that we're serving at the very outset and set the tone for their treatment and for our work together. And I always emphasize to people that they have a lot of rights. So talking through confidentiality, helping people understand what that means, what the exceptions are. I think as much as possible, we want to offer people choice when we can. One of the things I also really emphasize to people is that they have the right to complain. I don't think people in my position tell people sitting across from me often enough that they have the right to complain, and that's actually really important feedback for us. So the more we're able to involve members in their own care and let them know that they have a stake and really kind of create this notion of them as stakeholders in our community, the more trauma-informed we'll be. When we're working with people who've experienced trauma, we absolutely want to be as consistent as possible. So we want to let someone know what we're going to do, and then we want to do it, and then we want to ask them if they have any questions about it and how that was. When I ask questions about people's background or collect information, I like to explain to people why I'm asking. I like to give them options. So we were talking, on the last slide about the need to ask about trauma histories at the outset of treatment, but that is not the same as needing to collect from people all the details of their trauma history. So I normally let people know that it's important for me to ask about this, and it's really important that you set the pace of how much you want to tell me and when. And the more I know about your history and some of the things you've experienced, the more I'm able to serve you in a way that feels meaningful to you. And that's a really personal decision that I trust you to make, that our relationship is going to take time to unfold, and we're going to go at your pace. So we want to give people options and let them know what they can expect. I mentioned earlier that there's a difference between trauma-specific treatment and trauma-informed care. So trauma-informed care is kind of a broader philosophy and a framework for a system or organization. That's kind of our umbrella term here. And trauma-specific services are part of trauma-informed care. So this might include things like EMDR is a trauma-specific service that not all agencies are going to be trained to do, and not all people within an agency are going to be trained for. So the key thing about trauma-specific treatment services is that we only want to provide them when we're trained and knowledgeable and have a level of expertise in them, but we can absolutely provide trauma-informed care even if we aren't trained in trauma-specific treatment. And then we're going to talk more about safety in just a couple minutes, but as much as possible and first and foremost, we want to help establish a sense of safety and keep that as our focus. So going back to the people that you serve, I'd like you to list out what opportunities you see to respond to them through a trauma-informed lens. So what are some policies, procedures, and practices you can implement? what are the things you're already doing well? And what changes would you like to make at each of these 3 levels? Okay. So that brings us to the last R of SAMHSA's 4 Rs, which is actively resisting re-traumatization. And I like their focus on being active, that it's not something we're just hoping doesn't happen. It's something that we are taking a proactive stake in. So we want to consider the setting of the facility and environment. So we want to think not just about physical safety, which is, of course, crucially important. If the space doesn't feel physically safe, then that's going to be a real barrier to resisting re-traumatization, but also thinking about the emotional safety. So I'll give you an example. The program I work in right now is a substance use treatment program that's co-located in the ground level of a housing program for people who are dually diagnosed. So in some ways, it's an excellent opportunity to be right in the same building. However, our space is not designed to be a treatment program. So we are currently, our group room used to be the cafeteria for this building. So it is just a large open room, and there's several offices that open right into this space, and the door to our program opens straight into the space. There's no private walls to our group room. So, you know, one of the things that we've really tried to do at our program is, one, work with what you have, because I know that agencies are not always operating with ideal set of circumstances or resources, so we have to work with what we have. But one of the things we really consider is the emotional safety for people in group when there are people walking in and out of their group room during group counseling. And how does that affect someone's ability and likelihood and sense of safety to open up about something that's been occurring in their lives when there are a lot of disruptions and people could be walking by? So some of the things we've done are try and strategize around, you know, reducing disruptions, letting people know what they can expect, and then, you know, using other entrances to the building as much as possible. So, you know, I think it's a good example that it's not ideal, and eventually our program has plans to move, but a lot of times we're not working with ideal situations, and so what can we do to consider people's sense of physical and emotional safety in the space we have, and what can we do to be active in trying to resist a sense of re-traumatization? And one of those things that we can do is collaborate with people to create what's called a crisis recovery plan. So that's something I really think of the idea or the phrase, to strike while the iron is cold, that we want to ask people about crises before they happen. So a crisis recovery plan is going to consist of questions that we address with someone and want to know things like, what are signs that things are starting to escalate? How will we know if that's happening? What kinds of things help in those instances? What makes it worse? Who are the people in your support system, and who are the people on our staff that can be helpful in those situations? This could also include, this is, you know, along the lines of an advanced directive, but could include things like, is there a specific hospital that you like to go to if you're going to go to the hospital? But really being able to proactively assess with someone, how will we know if things are starting to escalate and what will be most helpful? Along those same lines, we want to try and prevent crises before they happen and have our staff be trained in de-escalation techniques so that we don't get to that point as much as possible. I think of the difference between being cautious and fearful. That when we're cautious, we're being proactive and intentional, and that this is based on risk factors, whereas being fearful is really reactive and emotional. In order to have a system that is resisting re-traumatization, we also need to be providing trauma-informed supervision to staff. Staff are absolutely affected. One of the things that I really enjoy about our agency is that we have what's called debriefings that we offer to staff members when there's been a loss on the team, some type of really critical incident or traumatic event, where we're able to set aside some time as a team to debrief how is this affecting staff and how does this affect your work and what do you need in order to move forward. So some strategies to be proactive in terms of resisting re-traumatization is really having a trauma-informed leadership, which we've kind of touched on, but that this isn't a trauma-informed care isn't something that we can do as individuals. We can absolutely be trauma-informed individuals, but we're trying to create systems of care, and we're trying to move away from this idea of trauma and trauma-informed care being specific to individuals in response to their individual traumas, but looking kind of at a broader, bigger picture lens. And that's it's gonna absolutely require that we have buy-in and support from leadership. When they talk here about data collection and use within an organization, that's the idea that we have a lot of information about the people in our program, and we collect a lot of information about the people in our programs. So how can we use that data in service of actively resisting re-traumatization, both of staff and the people being served? So what do we know about the people in our programs, and how can we apply that in a way that keeps everyone as safe as possible? Workforce development here, I think, really ties in with trauma-informed leadership, but this talks to, this speaks really to different practices as staff move throughout our organizations. So this starts with things like how are job descriptions written? In the hiring process, how are we screening for people's competencies and understandings and strengths around trauma-informed care? When we onboard people, how do we kind of maximize this new beginning with staff and set the tone very early on that we are a trauma-informed organization and help new staff know and understand what that means? That's also going to require, once people are in the door, that we have ongoing staff training and development opportunities, and that we assess people's competencies and incorporate trauma-informed practices and assessment into performance evaluations. That this is not something that we just do, you know, every once in a while when you participate in a webinar, but it's something that is ongoing throughout our work. I think that trauma-informed care also, in terms of workforce development, looks at what language is used in your program. How do you refer to the individuals that you serve? What types of words do you use to describe them in your clinical meetings and morning reports? And then absolutely reducing and ideally eliminating the use of restraints and seclusion is a key part of resisting re-traumatization. And SAMHSA has a really nice roadmap for ways to support agencies in moving away from that, because it is not at all really in keeping with trauma-informed care and is very re-traumatizing to the people who experience it and the people who enact it. And then we also want to really include people receiving services and their communities. Those are ways that we can be proactive in implementing trauma-informed strategies. And then last but not least, we want to continue to assess how's this going, to debrief as teams, as programs, and to be able to make adjustments for us to have the humility to say, you know, this practice we're doing, I'm not sure that it's really in keeping with trauma-informed care. And what does it mean for us to be engaging in this practice, particularly if we're getting feedback from the people that we're serving, that this is not helpful and may be contributing to people being re-traumatized. So we need to be willing to readjust when we need to. So we're going to revisit these two individuals one last time for today. And I'd like you to identify what kind of safety concerns are potentially associated with serving this individual. And what plans can you put into place that will be proactive in resisting re-traumatization and helping to maintain safety? So we're coming to the close of our time, and this last little bit, I want to leave some time for questions. I know we've had a couple. And also this last part is kind of asking questions that we can, I'd be happy to discuss here as a group, but also for things to really consider. So again, part of being able to like assess and adjust is to ask the question, how trauma-informed are we? So I'm curious where people see areas where your organization demonstrates trauma-informed responses, and what are the things that you feel like are going well, and what are areas of concern or further development. I also want to spend a minute kind of looking at the two individuals you considered throughout our training today. Really look at like what's different about them. I think that that's part of trauma-informed care, is being able to know and recognize that we respond to different people in different ways. And some of that is just, you know, the reality that we're just more naturally aligned with certain people. We're going to be a better fit with certain people. And that there's also very often a lot of situational differences about the people that we serve. And I think it's helpful. I know I've noticed in doing similar exercises throughout the years, but there's different types of ACEs that are more challenging and some that are a little bit easier for me to work with. And so that's part of me practicing trauma-informed care. So when I work with someone who's experienced some of the ACEs that I know I tend to have more difficulty around, that's a cue to me that I'm going to need to seek more supervision and consultation around this person, because this is someone who I may have more difficulty maintaining a trauma-informed stance with. So one of the things that I really like that you can have your agencies do, if they're willing to pay for it, is called the tachometer. And this comes from T3, who are folks out of the Northeast, and it looks at how trauma-informed your agency is across 5 domains. So building trauma-informed knowledge and skills, establishing trusting relationships, respecting service users, fostering trauma-informed service delivery, and promoting trauma-informed policies and procedures. So they'll actually work really closely with agencies to assess and then identify some strategies to improve the degree to which you're trauma-informed, so you can be higher on the tachometer. So with that, I'd like to thank you all for taking a couple hours out of your morning to spend some time thinking and talking about this. And I'd love to know if there are any questions that folks have.
Susie, thank you so much. There are a few questions that have come in, and we do have some time. We've got a few minutes. So I'll go ahead and jump into them if you're ready.
Sure.
Okay, the first one is it safe to put the youth who experience PTSD in the realm of pretending within social circles when teaching them to cope and develop their coexisting relationships? For example, smile more, be cheerful, it's okay to laugh.
Okay, those examples are helpful. Sorry, Leanne, can you repeat that first part of the question for me?
Of course, anytime. It's this. Is it safe to put the youth who experience PTSD in the realm of pretending within social circles when teaching them to cope?
You know, I think that we want to have a multifaceted approach, right? So if learning some social skills like smile, learning some basics of like social interactions and ways to kind of cope and endure in social settings is going to help that person get through with that, then yes, that is a helpful tool. Is that sufficient? No. So it's kind of a both and, right? Like, yes, that's something we can do, and we also really want to be supporting the person and hearing from them what they think will be helpful and what their needs are.
Thank you, Susie. Next, in your experiences, what method of questioning is best used for youths with not wanting to open up to answer or receive sexual trauma help, especially young males?
Yeah, so that's a great question. I am a really big proponent of motivational interviewing. So I think that that offers some really concrete tools for interacting with people who we might call like hesitant or resistant to treatment. But it really gives us a good skill set for interacting with people and building rapport, and focuses on establishing a relationship first and foremost. One of the things that I like to think of when people ask about, you know, folks who don't want to open up about certain things, just the idea that there's people in my life who can ask me certain questions, and that's okay and appreciated. And then there are other people who, if I don't know them very well and they want to ask me about some really personal things and talk to me about that, I'm not going to be so receptive to that. So I think focusing on building the relationship and using a lot of the skills that come out of motivational interviewing would be a really good place to start.
Okay, and I think we have time. I'm going to try to get through one or two more questions. What do you think about medications, or what do you think about the medications being suggested which appear to impact the neurotransmitters for entrenched trauma for people who have never had a chance for treatment? And I can repeat it if you need it.
Yeah, no, I'm just thinking. You know, I feel torn about medication. It has its place and utility and value. And so much of trauma is relational. You know, for someone who doesn't have opportunity to access treatment, medication is one route. I think more and more we're seeing opportunities for other body-based treatments, so things like yoga, mindfulness practices. So I wouldn't, I mean, I always like to give the disclaimer that I'm not a medical professional, but if you know, I wouldn't necessarily recommend just medication alone for someone, but absolutely it's been incredibly helpful for people, you know, especially with things like nightmares. If you just can't sleep, going to be really hard to access any other kind of services, but I would recommend pairing it with something like mindfulness practices or yoga that helps people reattune to their bodies.
Susie, I'm going to give you one more, and it may be a little too specific for you, but and if it is, just say so. But this is our final question. What strategies can you recommend to working with a 9-year-old who has experienced severe neglect? The patient continues to hoard food and has tantrums, et cetera.
Wow. You know, I think that with anyone who is presenting in that manner, one, we want to build a relationship, and I think that with a 9-year-old, that's going to look a little bit different. So I think with someone so young, I might use like some more play-related activities, you know, for something like hoarding food, maybe something that involves turn-taking. But I think anything that will help build a relationship and then really normalize, and this is a vast, you know, it's a quick answer to a really complex question, but I think to normalize that I understand where that's coming from and to help the person understand where that's coming from, not to take that behavior away from them immediately, but to help kind of change their relationship to the behavior. So if someone's hoarding food, they might continue to hoard food, but I think, you know, it's a really different behavior to hoard food with an understanding that I've lived in circumstances where I didn't know if I was going to have enough food for my next meal versus I just do this and I don't really understand why and I don't feel very good about it.
Susie, thank you so much. We so much appreciate you, taking time to share your expertise with us today. That's all the time we have for our questions. We've had a great turnout, over 400 individuals participating on the call today. And so in case you may have joined a little bit late and you missed it, please do be aware that when I end the event today, when we conclude the webinar, you're going to be directed to an evaluation form that you'll need to complete in order to receive your certificate of attendance. However, if something happens with the computer and you don't get automatically redirected to the evaluation form, that's okay. I'm going to be sending you a follow-up email in about 30 minutes, and that will have embedded in it another opportunity for you to complete the evaluation. So that's going to work fine also. And then, so finally, in closing, I want to thank all of our participants for today and for your time. And then one more thank you to Susie. And then finally, thanks also to the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's webinar. So in closing, just have a great rest of your day, and please hold now for the evaluation. Thank you.